You're listening to Beyond Wellness Radio, bringing you the cutting edge in health, nutrition, and sports performance. Stay up to date and listen anywhere, anytime on your computer, tablet, or smartphone by subscribing on iTunes. Catch your hosts, Dr. Justin Marchegiani and Barris Harvey, as they answer your burning health questions as well as interviews from world-renowned guest experts. For more Beyond Wellness Radio, go to beyondwellnessradio.com.
Hey there, this is Dr. Justin Marchegiani, and welcome to another awesome episode of Beyond Wellness Radio. Again, we have a great show in store for you. Before, go to beyondwellnessradio.com. Click on the newsletter sign-up button. You can sign up for our newsletter and get show updates right in your inbox before anyone else. You can also click on the questions button and even speak questions live, and we'll be able to answer it on the air for you. You can also click on the write a review button. If you really enjoy the show, write us a review. Let us know on iTunes. Let the world know. Think of one person that would benefit from listening to this show and share it with them. Sharing is caring. Also, check out justinhealth.com, which is my personal site. Again, I have some complimentary functional medicine consults available. You can also sign up for the free thyroid series and female hormone series as well. You can also go to reallyhealthynow.com. That's Barris Harvey's website, where he has some great articles and blogs and videos for you there as well, and even some consultations. Again, we have an awesome show in store. Stay tuned. Hey there, it's Dr. Justin. Welcome back to Beyond Wellness Radio. Again, we have an excellent guest on today's show, Dr. Will Cole. Dr. Cole's practice is over in Pittsburgh, Pennsylvania. He also has a virtual clinic worldwide. Dr. Cole is a functional medicine doctor. He specializes in thyroid conditions and much more. Again, as functional medicine doctors, we really have to specialize in the whole body. But again, Dr. Cole, welcome. Tell us about yourself a little bit.
Hey, thanks for having me, first of all. As you said, we have a clinic here in Pittsburgh, Pennsylvania. We have a virtual functional medicine practice where we do webcam and phone consultations for people in the United States and around the world. Clinically, just my education background, my doctorate is from Southern California University of Health Sciences in Southern California, and my postdoctorate, as you mentioned, is in functional medicine and clinical nutrition. So I also write for Mind Body Green, one of the largest health websites in the world, one of their health experts for the last couple of years. And I have a passion for educating people about chronic and autoimmune conditions, and I'm really excited to talk with you about the thyroid today.
Well, really good. So tell me about your health story. Every functional medicine doctor has their own story of how they got into this field. So how did you get into this field?
For me, it was just kind of growing up around it. My father was in the healthcare field and just kind of seeing some great minds, people like Dr. Mercola, that kind of changed the landscape of the healthcare in the United States and really everywhere. And they just inspired me, and saw people that are really struggling with chronic issues getting more and more medications and seeing that all be reversed and get healthy, and their doctors are able to take them off that medication. It's hugely inspiring as a young kid growing up. And I kind of knew in high school, hey, I want to be a part of this too. I want to make some changes in people's lives for the better too. So that's kind of with me. I know a lot of clinicians have kind of gone through some major health issues that was the catalyst to make them where they're at today. For me, I've been blessed and lucky to not have to go through that. So that's my story.
That's great. Awesome. And again, we are really fortunate because PaleoFX is coming up here at the end of April. So anyone that's going to be in the Austin area, Dr. Cole and I will be on a panel with another naturopathic physician. We'll be talking all about thyroid. So the goal of today's talk is to kind of give everyone a sneak preview of some of the things that we're going to be talking about in the thyroid realm. And again, thyroid is one of these conditions that's so common in the U.S. Mm-hmm. About 30 million people have this condition, and about 1 in 5 are autoimmune. And functional medicine really is the only field that's equipped to addressing the autoimmunity, because it's kind of a one-size-fits-all in conventional medicine. Can you talk more about how you address just your typical thyroid patient? So they come to you, they have maybe hair falling out, fatigue, depression, weight gain, the whole 9 yards. How do you work them up?
Yeah, I mean, I think that you're right. This is a huge problem in the United States. I mean, I think research shows like 20 million Americans have low thyroid issues. 1 in 8 women will develop a thyroid issue in her lifetime. And worldwide, it's insane. There's like upwards of 250 million people around the world have some sort of low thyroid issue. It's huge. And the inadequacy of the standard model of care is like glaringly obvious because they're just running these basic labs, TSH, maybe T4, and it's based on just, hey, here's Synthroid, see you in 3 months. And that works for some people, and for a lot of people it worked for a little bit, but then it plateaus and they're kind of left where they began.
Right.
And the reality is, as you know, I know that you're kind of seeing this on a daily basis in your clinic, is that we have to look beyond those sort of basic labs. And that's where it kind of starts with, for myself, and I'm assuming you as well, we need to run a full functional thyroid panel to kind of see the intricacies, these underlying pathway dysfunctions that are at play that will not be effectively addressed with Synthroid alone or at all.
Right.
So
right.
It starts with diagnostics, so a full thyroid panel, which you probably talked about on your show in the past, kind of the extended panel. And then we look at all the implications hormonally that are interplayed with the thyroid as well. So we look at adrenal function, we look at hormonal function as far as estrogen, progesterone imbalances. And then obviously the gut is a huge component of that as well.
Yeah.
So the conversion pathways as well as the total immunological standpoint, because a large part of these people have an autoimmune component to their case. So until you deal with the root issue, what's causing the low thyroid problem in the first place, which I would say the majority of them are autoimmune in nature. They may not be full-blown Hashimoto's disease, but they are in some degree their immune system's attacking their thyroid. So we have to have a comprehensive view of it, and then you kind of know definitively, okay, this is why you feel the way you feel, and let's start addressing these issues one by one.
That's great. Now, you talked about a full thyroid panel. Can we just, for all the listeners, just kind of contrast maybe what a conventional thyroid panel would entail, and then how a complete thyroid functional medicine panel will be different, and what extra information are we getting from that?
Right. So I think it'd be good for us to go back up a little bit and look at the main differences between functional medicine and mainstream medicine. The first thing that you and I are going to do different than their standard endocrinologist or PCP is that we're going to interpret the labs that are run currently, the ones they typically rent. We're going to interpret those labs differently because, on that reference range, they have, from X to Y, this is where your numbers should be. Anything outside of that range is high or low. It's a bold font, and there's a problem there. But we get that average through a statistical bell curve average of the population of that lab. People that typically go to labs are not the healthiest population. So if your doctor is saying, hey, your labs are normal, and then you're still going through these laundry list of symptoms, what they're really saying is you're a lot like a lot of other sick people, because it's just looking at this very general, huge reference range. So we, as functional medicine practitioners, are looking at a much thinner range of where your body's functioning the best, where your health is great, you're off of medications, you're not having symptoms, you have all that energy back, you're at the weight that you want to be. That's the optimal range, and that's going to be a lot thinner range than that huge reference range. So we're interpreting the labs that are run currently, the ones that you guys have from your PCP or endo, differently using a much thinner guideline. And then I would say number two, we're running more extensive labs that aren't run. And the reason why they're not run is not because your doctor is some nefarious, keeping you in the dark. It just doesn't change the treatment. You're going to get Synthroid or levothyroxine whether you have true primary hypothyroidism or an autoimmune disease attacking the thyroid or whatever other conversion issue or metabolic issue you're dealing with. The end result's going to be the same. So why would they run more labs if ultimately the only option they have to give you is that Synthroid or levothyroxine? So the full thyroid panel, in regards to your question, is that we are running beyond just the TSH and T4. We're looking at free T4, free T3. So those are the free forms of that thyroid hormone. What's biologically, metabolically active to the body? What's getting in the cells that's usable by the body? And then we're looking at T3 uptake, which looks, in our realm, the functional medicine realm, looking at estrogen and testosterone imbalances, and we're looking at, again, all the other implications beyond that too. So the free fraction hormones, we're looking at the T3 uptake, and of course we're looking at the antibodies, thyroid peroxidase and thyroglobulin antibodies, to rule in an autoimmune component to the patient's case. So the most common being Hashimoto's disease, which I'm assuming many of your listeners are the learned. They know what they're talking about, and they're aware of the rise of autoimmunity in the world and how we need to address it.
Yeah. And is TSH a thyroid hormone, Will?
Well, it's secreted by the brain. It's secreted by the pituitary gland. So it's not a thyroid hormone. It's kind of like the analogy that I use, and maybe it's not the best, but I always say it's the communication with the brain and the thyroid. So if your TSH is high, it's just like inversely proportional. A lot of people get confused. A lot of my patients do. Well, they're looking at this high TSH and they think, well, maybe why shouldn't I be hyperthyroid? Why am I not losing weight? Why am I not feeling like hyperactive? But this is an inversely proportional number from your brain to your thyroid. So it's basically your brain screaming at your thyroid if you have a high TSH saying work more because it's not secreting hormones for whatever reason. But again, there's a lot of people with normal TSHs that have low thyroid issues. One of them being a pituitary hypofunction. If your pituitary gland's not working well because of stress or inflammation or chronic infections, your brain is not communicating with your thyroid. So you can have a normal looking, pretty looking piece of paper, lab TSH, but you're having low thyroid symptoms. And that's why we have to look at these communication lines with the brains. That's a large part of my clinical approach is having a brain-based component to it, of addressing these neurotransmitter issues and these hormonal communication lines with your endocrine system.
Yeah, and a lot of patients I see, again, their TSH may be normal, but then their T4 to T3 conversion's off. Or let's say a patient had thyroid issues. Let's say, they had elevated TSH. They were put on some Synthroid. Now their TSH is back to normal, so the doctor thinks they're fine. But when you run a full panel, you see the T3 free and total is totally low. And one of the big things I think a lot of medical doctors don't realize is that the cells of the anterior pituitary are very sensitive to thyroid hormone. So once someone's on a thyroid medication or supplement that may have endogenous thyroid in it, TSH will be the first thing that drops, and you may not get that conversion across. Can you talk about medications and how doctors are so just focused on TSH and not the other downstream hormones?
Yeah, I think that really it's part of the bigger picture that we see across the board with all chronic disease. It's the training and the standard model of care that has its place, but their training is to diagnose the disease and match it with the corresponding drug. It's really the only option they have as far as the PCP setting. So if you have high cholesterol, you're going to get the high cholesterol drug. If you have the diabetes, you get the diabetes drugs. If you're depressed, you get the antidepressant. It's just this medicinal matching game. But when in regards to the thyroid is that it's just a very incomplete view, and kind of hanging your hat on this one number. We're all more complex than just one number on a piece of paper. And you kind of have to look at the downstream, like you said, conversion issues that the thyroid has to go through to actually be used by the body. So as you mentioned, low T3 syndrome is a huge problem around the country because the conversion happens in the liver, in a smaller part in the gut. This is where the conversion of T4 to T3 occurs. And if your gut's not working well, and if your liver's not working well, you can have low T3 syndrome or that just under conversion issue. And you have to deal with the conversion at that point. It's really not a thyroid problem. It's a conversion of the thyroid problem. Yeah,
that makes sense. Now, regarding, thyroid issues, we know T4 is this inactive thyroid hormone. Are you aware of any physiological uses in the body for T4, or is it primary T3?
Yeah, it's primarily T3. I think to a smaller degree, it's usable to some degree, but no, the more metabolically active is going to be T3 for sure.
Right. And most people or most doctors aren't looking at this conversion. What factors are you seeing that are affecting T4 to T3 conversion? You mentioned gut bacteria with the acetic acid and the sulfatase enzymes. You mentioned the liver with the whole deiodinization process. That's your body cleaving iodines off. It's a selenium-based process. We need selenium to do it. What other processes are really important for that T4 to T3 conversion?
Yeah, I would look at, again, a full mapping of the hypothalamic pituitary adrenal axis, the HPA axis, because if someone has sustained high cortisol levels or anywhere on that sort of adrenal fatigue, as we call it, spectrum, even just chronic stress levels, chronic systemic inflammatory issues will decrease the conversion ability of T4 to T3. So you kind of have to look at a complete history, and I think a lot of clinicians aren't even taking the time to really look at it. You have to look at these underlying issues that give rise to chronic thyroid symptoms.
Exactly. And you mentioned cortisol there, and we know that high cortisol will actually block T4 to T3 conversion, and we know if it's too low, if we're in a full-out adrenal fatigue stage 3, not enough cortisol will prevent conversion as well, because we need some cortisol for this conversion. And I see a lot of patients will kind of look at their full thyroid panel on one side, and then we'll look at their adrenal panel on the other. And some people, their adrenals will be in worse shape than their thyroid. How many people, or just on general, how many patients are you seeing on average that are coming in where their adrenals are actually in worse shape than their thyroid, even though they thought maybe they had a thyroid problem primarily?
Huge percentage of people. I mean, because you're talking about these all-encompassing, classical low thyroid symptoms, and then they think that's what they're going through. That gets the most buzz. That's the most popular. That's the most people are aware of in their consciousness. But when you run the labs, you're seeing, okay, actually you have a lot of other hormonal things going on, but it's actually not your thyroid. I see that on a daily basis. So you cannot sort of pigeonhole these issues and just assume they're all thyroid issues. Thyroid may be a part of it, but it's basically victim of these other hormonal problems.
Yeah, that's really true. And what nutrients are you also looking at to assess, or what nutrients are you making sure the patients have enough of to maximize thyroid conversion?
Yeah, I would definitely look at selenium, zinc issues, which help with the conversion issues and just help with thyroid physiology as a whole. And that's something that you can measure on a simple blood test to kind of see what's going on as far as the micronutrients are concerned. And many people are deficient in these nutrients. So those are two main nutrients that we look at.
And what objective tests are you doing to assess these nutrient levels?
We're running a blood panel, full blood panel to kind of see the micronutrient aspects of it. And as far as the nutrients, it's mainly through blood.
Are you doing like a SpectraCell? Are you doing like a Nutri-Eval? Are you doing just a
SpectraCell is typically what we use.
Okay, got it. Do you have any experience doing like a Nutri-Eval by Genova or?
I've seen them before from other clinicians.
Organic acid test?
Yeah, I've seen them before. We don't run them on a regular basis. Do you run them?
I do the organic acids a lot. I mean, there's some markers on your conventional blood panel where you can kind of infer some nutrient deficiencies, alkaline phosphatase and zinc and RDW and selenium, but they're indirect markers. But yeah, SpectraCell is a good one too.
That's my favorite one to looking at the nutrients.
Yeah, and what are you doing to look at liver function? Because we know that liver is so important for thyroid hormone conversion.
Yeah, what I'm doing is I'm running a comprehensive metabolic panel and looking at the AST, ALT, and the GGT and looking at the functional range, not just the huge reference range, but looking at the liver enzymes in the optimal range on the blood test that a lot of these people have already. So I always tell patients, look, we can start with the labs you have already and just the functional medicine interpretation of those labs to kind of see. And you know what? So many people don't even know what all these biomarkers mean. And just explaining to them, hey, look, this is what's been going on. Your doctor hasn't talked to you about it, mainly because there's no medication for it. But it's actually a problem, and your doctors ran these labs, but there hasn't been a conversation about it.
Yeah, that makes a lot of sense. That really does. Now, on that note, I have a blog up here in front of you that you wrote a little while back on autoimmunity and some of the triggers. Can you talk about just comparing, contrasting, your run-of-the-mill, your primary or secondary hypothyroid patient, whether it's a pituitary or conversion issue, and then compare that to just, an autoimmune thyroid. What's the difference, and how would you treat them?
And they can be separate cases, but my finding is that a lot of these patients have more than one thyroid category we would put them in. They are autoimmune, the majority of them, even if their antibodies are below the level where we can classify them as Hashimoto's. There's some sort of autoimmune response going on there. And then they have conversion issues, and they have pituitary hyperfunction. So, and they have thyroid resistance, which is similar to insulin resistance because of the chronic inflammation they're going through. So they have these multi-tiered, faceted aspects that are pieces of the puzzle to them healing when they overcome them. So, again, most of the patients that I see are autoimmune patients, and the large majority have been diagnosed or will be diagnosed with Hashimoto's disease or autoimmune thyroiditis. And a large part of autoimmune patients is finding out their food triggers, because autoimmune patients, as you know, they're given very little options in the standard model of care. They're really given steroid therapy, and that's basically it. And they're kind of left to fend for themselves. So, and they don't realize, and they're told by their doctor, hey, what you eat doesn't really matter at all. You can kind of eat whatever you want, and it's not going to play a part in your autoimmune disease. And that's just not what research is showing, is the foods you eat have direct implications to the rise of your inflammation and autoimmune response in your body. And I've seen every food under the sun, even healthy foods. I've seen autoimmune patients flare up against these seemingly innocuous, healthy, benign foods. So you have to kind of cut through the confusion. So people that have cleaned up their diet, people that are eating a paleo diet or kind of conscious eaters and clean eaters that are still having symptoms, we need to kind of cut through the confusion. What is their immune system flaring up against?
Got it. All right, so you mentioned some of these triggers, you mentioned some foods, and then would these foods just kind of be all the foods that would be, cut out of kind of your basic autoimmune diet, your nuts, your seeds, your nightshades, your gluten?
Yeah, those are the
potatoes, eggplants, peppers. Go ahead.
Yeah, no, that's the big guns for sure. We would clean those guys up right out of the gate. And then I run the Cyrex multiple autoimmune food panel, the newer one they have.
Number 4? Letter A 4?
I believe so. I don't know for sure. I think it might be autoimmune, because that's that's the cross-reactive foods, I believe. So it's not the cross-reactive foods, which we would run that as well, but they have, I think it's array 10. It's higher up in the arrays that kind of looks at just food intolerances as a whole. And obviously, no one really has like a spinach intolerance, but if their body's reacting against this, it's really due to the gut. So what I have them do is, while they're healing the gut, avoid those foods so they do not have this sort of inflammatory response against these healthy foods.
Got it. So patients come into you. What are the average tests that you're running off the bat? I know it's going to be different for each patient depending on what their goals are, but just on average, how many tests are you typically running off the bat, and what are they in general?
Yeah. The first tier test is going to be a functional blood testing, just through their labs, typically their Quest or LabCorp we typically use. So it's going to be a comprehensive metabolic panel. We run a nuclear magnetic resonance to look at the subfractionation of the lipids, and we're looking at the micronutrients. We're looking at a full thyroid panel, obviously. We're looking at homocysteine, C-reactive protein. Mm-hmm. We're looking at MTHFR gene mutations. That's kind of basic testing for us. Yep. And then the secondary testing is going to be full saliva adrenal stress index through diagnostics, looking at cortisol rhythm, looking at estrogen, progesterone, LH, and FSH, some basic food intolerances. And then we run a 2-day collection stool test from doctors' data to look at the microbiome. So predominant bacteria, any yeast, fungal, parasitic issues, bacterial overgrowths, leaky gut syndrome, and digestion and absorption abilities, because we see impairments of that a lot because of the population, the autoimmune patients that we're seeing. So that's basic testing that we run, and then we go a little bit deeper for patients that have cleaned up a lot of their lives, that are eating healthily, but they're just at a plateau, and we run sort of these deeper tests for those people.
That's great, Doc. And I know in your article here on 6 triggers for autoimmune thyroid disorders and how to avoid them, you mentioned infections, and you talked about your 2-day sample from doctor's data. Is there a reason why you do the 2 versus the 3?
I just think it uncovers things that may be missed on the 1 day, and they have a 3-day collection too, where we use that often as well. Okay. So I think you're just going to uncover things that maybe fall through the cracks. No test is perfect, and I just find there may be things negative on day 1 and day 2 and day 3 that'll be positive, and a lot of people can get these false negatives, and they go on for years of their lives not knowing why they're sick. And it's just, if we just took the extra day to run these labs to give them insight into these underlying things that are lurking but aren't easily detected.
Yeah, a lot of times I'll run 2 different stool tests from 2 different companies, minimum of 3 days each, Sometimes we'll even throw in one of the genetic stool tests too, and almost all the times one will pick up an infection where the other one didn't quite pick it up.
Yeah, that's brilliant. That's even better. So I think the more you can kind of give people answers into, hey, this is why you're struggling, and it's just, that's the beginning of healing. Them just getting that relief off their shoulders of, hey, I'm actually feeling this lousy for a reason. It's not just all in my head, because many people, as you know, are told this for years. Yeah. You're just crazy, or you're just depressed. Here's an antidepressant. And then they start second-guessing themselves and thinking, well, maybe it is just in my head. It's not just in your head. This is a real physiological issue that's really just, you're not getting the answers because of the inadequacy of the standard model of care.
Yeah, I had a patient just the other day come in, and she's a young high school student, and she has a bowel movement on average once a week if she's lucky. And she goes into her primary care, and obviously they just throw her the prokinetics, your laxative medications, your enemas. But then while leaving the doctor's office, the doctor tried prescribing her with anxiety. And it's like, wait a minute. Like, I think anyone would just naturally feel anxious if they couldn't poop, less than one time a week. It's like, come on. So that's the kind of standard of care where even when we have blatant imbalances in physiology, we're still going to try to make you feel like it's all in your head, and we're going to give you some medication that's going to probably cause more side effects than help.
Yeah, exactly. I think it's very well said. And it's just this very symptom-based model, which we've seen for decades here. And it's just, as far as crisis care, I think emergency care in this country, we have some of the best emergency care systems in the world. But when you're talking about chronic care, the daily chronic disease is really what's killing the United States, chronic disease and autoimmune conditions, we're a dismal failure. We're really very, very inadequate as far as the options that people are given.
I totally agree. And are you seeing a lot of patients of yours that are having these issues and are being scapegoated with antipsychotic medications?
Oh, absolutely. That's the easy drug to give. That's the easy solution. You have anxiety, you have depression, or you have these unexplained health issue, and they basically are saying it's a mental issue. They're basically making it up. It's part of a mental disorder, and they're given these antipsychotic drugs, and it's not dealing with the root issue of why they're going through what they're going through. And we know just through the cytokine model of cognitive function, basically how inflammation impacts brain function, depression and anxiety and these autistic type symptoms, all of these things have implications to the gut, to the microbiome, and to inflammation. Until you deal with those issues as real, measurable physiological issues, you're going to have these symptoms. And you can be doped up from medications, but ultimately you're not dealing with the reason why you have the problem in the first place.
Yeah, I totally agree. That makes a lot of sense to me. And I know that you being a functional medicine doctor, you have a systems-based approach where when someone's talking about their symptoms, right, they may talk about fatigue or brittle hair or my fingernails or this. You're in your mind, like going back, oh, maybe their adrenals are off, maybe they're not absorbing fatty acids and protein, where maybe the average doctor is like, let's see, depression, SSRI, stomach pain, proton pump inhibitor. So your mindset is totally different. You're working in a different way mentally when you're listening to these histories versus a conventional MD. Is that correct?
Yeah, absolutely. And another word for functional medicine is systems medicine, or mechanism medicine. So we're looking at these underlying mechanism dysfunctions that give rise to chronic and autoimmune conditions. So yeah, the symptoms are just the tip of the iceberg. Symptoms are a result of something going on underneath the surface. So we need to kind of backtrack and come up with a hypothesis of what's not working well, and then implementing natural tools to fix these underlying dysfunctions.
Yeah, I love that. That's why functional medicine just makes so much sense.
Yeah, it's logical. People that have a logical mind, or they just want to find out why. Who doesn't want to find out why they feel the way they feel? I think ultimately most people do not want to just mask symptoms. They may want that for the meantime. In the short term, if they're suffering, I understand that. But then long term, we have to ask the question, why do I have this problem in the first place? It's not a medication deficiency. So let's find out how we can get better, so eventually, as I'm getting healthier, I can get myself off these medications with my doctor's help.
That makes sense. Now, in your blog article here, which I recommend everyone to read here, the 6 triggers for autoimmune thyroid disorders at drwillcole.com. Click on the blog link there. But you talk about infections. We touched upon, how you assess that with, certain stool tests, 2, 3-day ones, etc. What infections are you seeing on average with your patients?
Yeah, we're seeing bacterial pathogenic infections.
H. pylori?
H. pylori.
SIBO kind of stuff?
Yeah, and strep infections too, overgrowth of those colony-forming units of bacteria. And we're seeing Candida, or not just Candida albicans, but different types of species of Candida, yeast, fungal issues, and occasionally we're seeing parasitic infections as well. So these type of things are constant, these cyclic inflammatory triggers to people that are struggling with these unexplained health issues that may be thyroid related, may have a thyroid component, and they just think it's entirely thyroid. But as we talked before the call started, the body's all interconnected.
Yeah.
And the idea that we're these separate boxes where we're just going to have a pill for each of our problems, the reality is that we need to look at the body as a whole, entire system, and start fixing these issues one by one.
Yeah, that makes a lot of sense. What kind of parasites are you seeing in your clinic with patients?
We're seeing really everything as far as the parasitic infections. It's not to pinpoint one. I don't really. Yeah.
Yeah, I know the scientific literature is really keen on. For instance, H. pylori is a big one. Yersinia enterocolitica. Those are big ones that are connected with the autoimmunity for sure.
Yes.
What's your experience with Lyme disease, and Hashimoto's or Graves' instance?
Yeah. We don't see very many, in my practice model, we don't see a lot of Lyme's patients. It's not really my focus, but the autoimmune component of Hashimoto's and Graves, that's the majority of our patients. And we have many patients that have Hashimoto's and many patients that have gone years of their lives thinking they have a thyroid problem, but again, the TSH is normal, but then when you run the antibodies, the thyroid peroxidase and thyroid globulin antibodies, it's through the roof. To be officially diagnosed with Hashimoto's, you need to have a high TSH and both positive antibodies, but they're somewhere on the autoimmune spectrum.
Yeah. Now, we can't have a talk on thyroid without touching upon iodine. So there's a couple different schools of thought of iodine. There's the Karazian approach, which is iodine for anyone is totally bad that has autoimmunity. And then we have, the Brownstein approach, which is, maybe some iodine may be really helpful, and we're going to give very high doses, up to 12.5 milligrams, maybe 50 milligrams, the Abraham approach. Kind of where do you fall in on that spectrum with giving iodine? And can you compare and contrast it with someone with Hashi's or autoimmune markers or not? Can you share that?
Yeah, and I've kind of been on both sides of this, and I'm more from the Disease-Karazian point of view. It's definitely from an autoimmune standpoint, so we definitely avoid it. I consider it a contraindication for autoimmune thyroid patients, only because what I've seen personally. The research, I've included the hyperlinks in the article on drwillcole.com for that as well. But just on a practical level, what am I seeing clinically? When I see patients on iodine when they're coming in here, I've seen people flare up because of that. So that paired with the research going on there, I think that we need to at least err on the side of caution when you're talking about iodine supplementation for autoimmune thyroid patients. With that said, if someone's clearly not an autoimmune patient and they're having low thyroid issues, iodine can be a great part of, in low dosage, a great part of them healing. So I think this is the bigger picture of what we both agree upon, is that there's no one size fits all, and even natural things, what works for one person may not work for the next person. So to make blanket statements and say iodine is not used for anybody, and then the other person says iodine is this magic pill for everything, I think that it's a little bit more nuanced, and there may be some generalities that are true, but we kind of have to look on it on a case-by-case basis.
And when you have an autoimmune patient, let's say you're fixing their adrenals, you're maximizing vitamin D, you're cleaning their diet, blood sugar stability, sleep. Let's say they're 6, maybe 9 months in, they're starting to do better. At what point would you start potentially maybe adding in a couple hundred micrograms of iodine? Would there be a point you may try adding in just a little bit once things are stabilized?
Yeah, I definitely feel like that. And if you run antibodies and they're negative, and we're talking about, I would say probably 6 to 8 months. Maybe it's a little bit more conservative of me, but that's where I would go. I would wait at least 6 to 8 months, let everything sort of heal, dampen, put into remission, and then, really low dosage, kind of test it that way. Because at that point, it can be the tool to push us past any plateaus that we find ourselves at 6 to 8 months into care.
Are there any markers on a lab outside of a SpectraCell or an iodine loading? Is there any general marker that you would look at on a thyroid panel to say, hey, maybe you could use some iodine supplementation?
I do the urine iodine test just through Quest or LabCorp. We do the random urine test.
How does that work? Can you walk that through our listeners?
Yeah, it's just a urinalysis from the lab. So typically the patients are going, we're sending them to LabCorp or Quest, and they're getting this, and we're just looking at the iodine levels and seeing where the levels are at. And if they are low, again, if it's an autoimmune case, I'm going to wait until we kind of calm everything down and then test it in low amounts. I'd rather them be a little bit iodine deficient than have an autoimmune flare-up and a thyroid storm. And that's just my personal opinion. I think that other clinicians have valid points as well. And then as they're calmed down and things are healed up, then we can kind of talk about very small amounts of iodine at a time.
So regarding that iodine loading, is there a loading dose that you would take before that test? Is that like a 50 milligram kind of Lugol's or iodoral capsule you take?
Yes, 50 milligrams, and we use that same, yeah.
So you give that to the patient, they go to the lab, they collect their blood that next morning, or their urine that next morning. Is that how it works?
Yes.
And then you're essentially looking for less. Like the less iodine in there means your body's taking it up. The more that comes back in the urine means you're more, I would say, sufficient. Is that correct?
Right. More,
Okay.
Sufficient. Exactly.
Okay, great. Any other comments on iodine? I know the whole iodination, that's a funny word. That's basically how your body takes iodine and binds it to tyrosine and makes thyroid hormone T4.
Yeah.
That process, I know when there's deficiency in selenium, we spit out a whole bunch of hydrogen peroxide, and that's one of the big cascades of the whole autoimmunity. Can you talk about how important selenium is to autoimmunity?
Yeah, it's a huge stabilizer to the immune system. So it's one of the things that we test, and typically we're just testing that from the SpectraCell lab. And it's one of the nutrients we need to re-inoculate the body with. We need to nourish the body with this nutrient to stabilize the immune system. So when there's a lack of it, it's a piece of the puzzle. Again, I don't want to make it as the magic bullet for everything, but it is a factor that I see clinically in people regaining their health.
That's great. Do you see patients with Epstein-Barr or reactivated viruses like Epstein-Barr, for instance, that's maybe driving their autoimmunity?
Absolutely, yeah. I think that research will show this as well, is that a majority of people that have autoimmune diseases have had some sort of viral infection, bacterial infection in the year prior to their diagnosis. So, yeah, it's a factor to them feeling the way that they feel, and you have to deal with these viral issues and bacterial issues and balancing the immune system as much as you can to regain that plasticity of their health so they can regain function back.
That's great. And do you have an approach on how you address viral issues?
Yeah, typically I use for viral issues, I use GI Synergy from Apex. So if it's like a microbiome bomb, gut immune bomb, do you use that as well?
I used to use that. I use a couple other things for viruses, mainly like very high-dose monolaurin, from what I understand is very good, and high-dose reishi mushrooms very good as well. Yeah, I believe the reishi mushroom is actually in GI Synergy as well. Oh, okay. That's cool. Very cool. So on your 6 Triggers blog here, you also mentioned gluten, and I think a lot of our listeners are probably very aware that gluten and the thyroid, there's this cross-reactivity, molecular mimicry with gluten and the thyroid tissue. Can you just touch upon gluten and how important that is with Hashimoto's patients? Yeah, I think it's a huge factor, and I think a lot of people, when they have a thyroid issue or they're diagnosed with Hashimoto's and they know that, they kind of beg for these labs from their doctor and they know they have Hashimoto's. They're kind of given no option beyond that.
And from my perspective, looking at the research, and again, you can look at drwillcole.com and all the hyperlinks going to the different studies, and I know you've written about it as well, is that this is kind of a no-brainer. You just cannot be eating gluten if you have an autoimmune condition. And I would say statistically, since the majority of low thyroid patients have some sort of autoimmune issue, that you should be off of gluten entirely if you have any thyroid issue, just to err on the side of caution. And because of the cross breeding of the grain supply in the United States throughout the years, it's molecularly a different beast than what we've known throughout history. So there's a mismatch between our genetics, our biochemistry, and the things we're eating's biochemistry. So that molecular mimicry that's going on, and the body's causing an attack against the gluten protein as well as your thyroid tissue and Lord knows what else. I mean, polyautoimmunity is a very common thing that we see in our clinic. People with 3 or 4 different autoimmune diseases, and this is being fueled in part by the foods that they're eating. And then people will give it like 3 weeks of this or 4 weeks of that, and they'll say, I didn't notice a difference after 4 weeks of being off of gluten. And the research shows it takes up to 6 months to downregulate some of the inflammatory cascades that are going on because of gluten. So, it's a big factor that people have to kind of stay true to it, and you can't just be a little gluten-free. It's like saying you're a little bit pregnant.
Yeah.
You're either pregnant or you're not, and you kind of have to stick through it. And it's a big piece of the puzzle. It's not the entire puzzle, but it's a factor into people regaining their quality of life back.
That's great. We've gone over a lot of stuff today. I think everyone's going to have to listen to this show twice, even myself. So I'm starting to ask my my interviewees here a couple of questions to end the show. So the first question I'm going to ask you, if you had to be on a desert island, and I took this from Mike Mutzel's podcast, but if you were on a desert island and you could only bring one herb with you, one herbal product, what would it be?
It has to be an herb?
Yeah.
Oh,
favorite herb?
Milk thistle.
Milk thistle, good. So you plan on doing a lot of drinking that on the island, right? And then what are like your favorite, that you would say the best 3 things you could do to optimize your health?
Okay. 3 things to optimize health. I would say eat good fats, avoid sugar, and eat lots of plant foods.
And then with fats, do you mean like olive oil or like coconut oil, fish oil? What do you mean?
Yeah, I'm talking about good saturated fats, like good grass-fed beef and ghee and clarified butter, and yes, and monounsaturated fats like olive oil, avocado oil. Yeah.
Great. Awesome. Well, everyone listening, you can find more of Dr. Cole at drwillcole.com. Doc, where else can the patients or all the listeners find you here?
You can find me on Twitter at drwillcole. So it's drwillcole. And yeah, drwillcole.com has all the links to me on social media. So you can follow me on Facebook, like me on Facebook, follow me on Twitter, all that good stuff. And you'll see us both at PaleoFX in Austin at the end of April.
End of April. It'll be a really good thyroid panel. We're going to be on 10 a.m. that Thursday, opening up PaleoFX. So we're really stoked. Anyone that really wants to get more hands-on information about your thyroid, and reach out to Dr. Cole, and also come to PaleoFX. And again, Dr. Cole also has his 14 life-altering health tips mini ebook on his site. So feel free, get that. That's a freebie. And Dr. Cole, it was great chatting with you.
Got a question for Dr. J? Go to beyondwellnessradio.com/question. Then tune in to hear the answer. Also, if you like the show, review us on iTunes. For more Beyond Wellness Radio, go to beyondwellnessradio.com.